I, on this International Women's Day and Mahashivratri, Arti Su Dewwan, welcome everybody on behalf of Indian Orthopaedic Association, WOICE, Women Orthopedic Indian Collective Empowerment, Geriatric Orthopedic Society of India. Hope everyone is doing well. Thank you so much for joining this evening on the webinar on comprehensive strategies for osteoporosis management, empowering bone health in India. As we all know that women's journey strives to improve the well-being through health education. As the age progresses, the body, it absorbs, as we know, the calcium and the phosphates, and it leaves our bone brittle and fragile. This process goes on and it leads to breakage of the bone, and that is called osteoporosis. So, we're going to talk about the management strategies. Now, I want to take this opportunity and acknowledge and thanks the President, Indian Orthopaedic Association, all the speakers and the expert panels and the moderators. Dr. Ram Chaddha, the President, Indian Orthopaedic Association, is a renowned spine surgeon in Mumbai, is also the Indian Orthopaedic Association Osteoporosis Council member, senior member. Professor S S Jha, Indian Orthopaedic Association Osteoporosis senior member and advisory, and the director in Harish Chandra Orthopedic Research Institute, patron of Geriatric Orthopedic Society, patron and founder and president of IORA, president Innovative Education and Scientific Research. Dr. S S Amarnath, he's a consultant trauma and orthopedic surgeon, Trinity Central Hospital. He's also Osteoporosis Council chairman and a director of the Geriatric Orthopedic Society India. Dr. Srinivas, I'll be thankful, he's a director and the consultant orthopedic surgeon in Shri Thatri Orthopedic Maternity and Gynecology Center, Vijayawada. He's also Osteoporosis Council member. He's the editor-in-chief general of arthroscopy, joint surgery, and also an associate editor, Indian Journal of Orthopedics. Now, I will welcome Dr. Ram Chaddha to address this webinar.
Good evening. Arti ji, thank you very much for the kind words. Respected dignitaries, my seniors, lovely ladies, it's your day. It's your Women's Day and Mahashivratri today. It's a pleasure to be here. We men are here because of you women, and I respect you and I pay obeisance to all, including the oldest woman that I know, which is my mother, who turned 101 on the 3rd of March, 4 days back. So with due respects to my mother and her blessings, I would want you to initiate how you can empower a woman both physically and mentally so that she goes beyond the age that my mother is at. Thank you very much. Let's go ahead.
Now I call upon Dr. Suma Balan, the Professor, Pediatric Rheumatologist and Head of the Department of Rheumatology and Clinical Immunology, Amrita Institute of Medical Science, to talk on building bone mass from childhood. Dr. Suma Balan.
Thank you so much for this opportunity and be sharing my slides. It's a great opportunity to be here among an orthopedic team to talk about something that is close to my heart. Normally, my job involves treating children with rheumatological disorders, and pediatric osteoporosis is a consequence of some of these disorders. And, pediatric osteoporosis is a definite entity. We have primary causes, secondary causes. They present with fractures as a definite definition. However, that's not what I'm going to be speaking out today. Today, I'm going to be talking about the big opportunity that childhood offers us. So before the age of 18 years, approximately 95% of the skeletal size and the bone and muscle mass is acquired. Childhood is therefore a very important time to build a strong musculoskeletal system. And in fact, the changes in the bone geometry show a marked increase in the trabecular bone development of the spine and long bones in late puberty. And then the cortical density increases rapidly when there is epiphyseal fusion. So that's why we all need to be talking about osteoporosis. We need to be talking about children. There are two very rapid phases of bone growth. One is from 0 to 2 years, and the other is at puberty. And if you look at the diagram, this is a famous graph actually. It shows you how with peak height attainment also comes peak bone mass attainment in children. Since girls have puberty that comes up earlier than boys, girls tend to lay down their peak bone mass even earlier than boys. In fact, the speed of bone buildup in the spine and the hip increases by approximately 5 times during the process of puberty. Boys actually have a greater advantage because their puberty starts a little later and goes on for a longer period of time. So they have a little more time to build up that bone mass. And another very important fact is that in girls, the bone tissue which is accumulated between that 11 to 13 years of puberty approximately equals the amount of bone that you're going to lose in the 30 years following menopause. And that's where the great opportunity lies. So what are the factors that influence the peak bone mass? We have genetic factors. So there can be genetic causes of osteoporosis, which is something that a patient cannot possibly control. There can be hormonal factors. So a number of things play here. And hormonal factors can definitely affect the accrual of bone mass. Then there can be nutritional factors. So good nutrition is key. The vitamin D, the calcium, and the protein intake. And there can be mechanical factors, which are extremely important. As you can see, impact and weight-bearing exercises increase the peak bone mass the most. So this is another really important diagram. So here you're seeing how between the ages of 10 and 20, so towards 18 years, there is actually the peak bone mass that is developed in the childhood skeleton. And after that, there is only a very small amount of accrual that you can see, following which it starts going down. And after menopause, the rate of loss is a lot more faster. Now, those children who are unable, for whatever reasons, to accrue that, the ideal peak bone mass are far more likely to enter the osteoporotic section of the bone mass in their later years of life. And this really is the opportunity we are all talking about. So the WHO, in their statement on osteoporosis, has actually included a lot of specific recommendations. So they have got dietary recommendations for children with regard to calcium and protein intake according to age. They have also got a strong recommendation that children between the age of 5 and 17 years should accumulate at least 60 minutes of moderate to vigorous intensity physical activity on a daily basis. But what is the reality for our adolescents in India? Many of them have physical inactivity for the major part of the day. They have indoor existences. And the current, the exams and their coaching classes are all part of this problem. They have dieting fads. They are into caffeinated beverages and colas, which are, very bad for the bone growth. Many children start developing alcohol intake and smoking during their adolescent years, which are again significant factors that affect their bone mass accrual. And essentially, it is a peak bone mass versus peak bone mass situation in these children that we are subjecting to these days. So I'll finish very soon now with just my recommendations. That is, childhood growth and development. We have to understand that provides us a big opportunity for peak bone mass accrual, which is the most kind of primary prevention for osteoporosis that we can start undertaking. We have to be really careful against this all work and no play, which is what the current schema for most adolescents seems to be. We also need to think about whether we should be considering food fortification with calcium and vitamin D, because I'm sure most of our youngsters don't probably get in the intake that they are supposed to get. We have to start thinking about early referral for children with chronic diseases that can impair the bone growth, because treated by the right individuals, they can actually have the least consequence to their bone growth. And I would like to end by saying that osteoporosis is a pediatric disease with geriatric consequences. Thank you.
Thank you, Thank you, Dr. Suma Balan. It was such a nice and informative talk regarding that building up of the bone mass in from the childhood. So from the childhood, we should take into consideration that our bones should be strong enough, and fortification of the food is required. What I meant, right? Now, thank you so much. Now I invite the next speaker, Dr. Susheela Rani. He is a medical director and consultant, Manjushri Specialty Hospital, Bangalore, is the past president BSOG. Now to talk about role and sources of proteins in nutrition to prevent osteoporosis. Dr. Susheela.
Yeah, thank you very much. And thanks a lot to the organizers for choosing a very appropriate topic to address on this International Women's Day. I'm going to talk on the role and source of protein in preventing osteoporosis. How do protein help bones? When we talk about bones, we are often thinking about calcium, vitamin D, etc. We need to realize that protein is a major macronutrient, which is very important in the formation of bones. Dietary proteins provide important components for both bone and the skeletal muscle mass. They provide amino acids essential for the synthesis of the bone matrix and the skeletal muscle proteins. And there are specific amino acids such as branch chain amino acids, which stimulate gene expression of insulin-like growth factor 1, which is a hormone that exerts anabolic effects on the bone and muscle. So amino acids are responsible for the anabolic effect on the bone. And whey peptide is known to decrease the bone and muscle breakdown during aging through its anti-inflammatory pathways. Now, we know that dietary protein increases bone density, and therefore it increases the density of bone both in the hip and the femoral neck. And a decrease in the dietary protein can bring about hip fracture risk reduction, and it also helps in reducing the hip fracture risk by almost 11%. What happens when there is insufficient dietary protein? This leads to muscle wasting. And we know that lean muscle mass affects not only the overall bone mineral density, but it also causes key cross-sectional bone parameters related to bone strength. Now, there is bone loss and fragility fractures whenever there is an insufficient dietary protein, especially so in older individuals. And this is often preceded by the loss of muscle mass and strength. It was once believed that a high dietary protein that one consumes, whether it is in the form of animal protein or plant proteins, can cause an increase in the physiological acidity. And this increase in physiological acidity is known to be detrimental to bone health. Subsequently, we had this systematic review and meta-analysis from the National Osteoporosis Foundation 2017, which worked on this specific issue and said that higher protein was associated with increased bone mineral density of various bones, and this was evidence level B. So it doesn't cause any decrease in the bone mineral density. In fact, it increases. So having said that, we need to know that the recommended dietary allowance for protein for adults is almost 0.8 grams per kg body weight per day. And for children, it is 1.5 grams because they have a larger growth spurt. And for adolescents and older people, again, it is around 1 gram per kg body weight per day. Now, this is the recommended daily dietary allowance of proteins. We look at vegetable proteins. They are rich in legumes, tofu, soy, tempeh, nuts, seeds, especially our groundnuts that are famous in India. They are rich in all these proteins. They may have poorer nutritional quality due to their variable amino acid profile because they might be missing some essential amino acids. Having said that, a mix of proteins can complete deficiencies in one another. Like if there is a deficiency in one particular item, that can be complemented by another protein source, and therefore one can never go into a complete deficiency of all the essential amino acids. On the other hand, animal proteins are called as complete proteins because they contain all the essential amino acids. Common examples are meat, fish, poultry, eggs, and dairy products. Now, the plant-based proteins are seen in chickpeas, oats, brown rice, quinoa, lentils, cashews, peanuts, almonds, etc., Whereas the animal-based proteins, eggs are rich in protein. You can see the amount of proteins in each, and then various kinds of fish, especially the tuna and the pork chop and skimmed milk. All these are rich sources of proteins from the animal source. Now, one would ask, which is better? Is it plant protein or animal protein? This particular issue was addressed by a meta-analysis of the NOF, and it showed no statistically significant difference between the plant protein-rich diet and the diet with a predominance of animal protein. So those vegetarians need not worry a lot because they are on a plant-based protein, whereas the animal protein and the plant protein are equally good. Plant and animal proteins have a comparable effect on both the bone mineral content and bone mineral density changes, an increase in the IGF-1 levels, which is potentiated by the soy products. A diet containing only plant products, however, is deficient in calcium and vitamin, and this is available in dairy products. So dairy products, apart from being a source of complete protein, they also deliver additional beneficial components of calcium, phosphorus, and aromatic amino acids. So a vegetarian gets all kinds of proteins, whereas a vegan might miss out on calcium, phosphorus, and aromatic amino acids. Now, we look at the category of postmenopausal women. Soy products would be the best source of proteins here. This is because of the beneficial influence of isoflavones, which are actually phytoestrogens. Postmenopausal state is an estrogen deficient state, and the phytoestrogens help in conserving the bone mass to some extent, and therefore the source of proteins, soy would be a better choice. Those with kidney disease, nuts, soy, legumes, fish, poultry, and egg would be a good source. This is recommended because the red and processed meats have an unbeneficial influence on kidney function, and they are generally not preferred whenever there is kidney dysfunction. Those with cardiovascular disease, they would benefit from poultry, low-fat dairy, fish, soy, and legumes. And this is because the red and processed meats, again, the high-fat dietary products and eggs are preferably avoided in those with cardiovascular disease. So to conclude, I would say that and so far, the results do not favor any particular source of protein in the diet, but protein definitely is very important in prevention of osteoporosis. Patients may benefit from increasing the quantity of protein consumed, and the sources of proteins are tailored to the patient's condition. Depending upon the comorbid condition, they can alter the source of protein. One caution is high protein intake might negatively influence bone quality in patients undergoing a bed regime. Very old people, very old postmenopausal women, where the physical activity is remarkably reduced, high protein intake can have a negative influence on the bone quality. So in such people, high protein intake should be avoided. I mean, the rest will benefit from protein. The source of protein needs to be according to the patient's condition. Thank you very much.
Thank you very much, ma'am. That was an excellent talk. Key message being proteins are very important for prevention of osteoporosis. We'll move on to the next speaker. It's Dr. Arti Su Dewwan. She conceived this webinar actually and approached us. She will be talking on calcium and vitamin D nutritional supplementation for osteoporosis. She's a consultant orthopedic surgeon in Amritsar, and she's IOA Osteoporosis Council member and the past chair for WOICE, the Women's Orthopedic Wing. Over to you, Dr. Arti.
Thank you, Dr. Srinivas, for such a words. Now, talking about osteoporosis, as we all know, it's a systemic skeletal disorder characterized by low bone mass and microarchitectural deterioration of the bone tissue with consequent increase in the bone fragility and susceptibility to a fracture. Aradhana, please next. So there's bone deficiency, thinning, bone loss, and weakening, as we all know. Aradhana, so the risk factors are modifiable and non-modifiable. That determines the quality of life and the life expectancy. Next, Aradhana. So the goals main is the prevention, stabilization, and improving the bone mass and the strength. Balanced diet with adequate intake of calcium and vitamin D is required. So what are the pillars for osteoporosis treatment? The diet, number one, the lifestyle, the pharmacological if needed, and the concurrent management of underlying causes if present. Now, talking about calcium, symbol is Ca. The atomic mass of calcium is 40.078. The atomic number is 20, and the electronic configuration is 4s2. The period is 4, and group is 2. It's an alkaline earth metal. Appearance, it looks like dull gray, silver, pale yellow tint. It is a matured Homo sapiens skeletal. In women, it 1.2 kgs, and in male, it is 1.5 kgs. Calcium, women should take 1,000 to 1,200 milligrams per day, and in male, the requirement is 1,000 to 1,500 milligrams per day. How it is absorbed, as we all are aware of, vitamin D and parathyroid hormones, they are required for the calcium absorption. So without vitamin D, absorption won't be possible. The normal serum levels of calcium are 8 to 10.5 milligrams per deciliter. The forms, the calcium we can take is the calcium carbonate, the calcium citrate, the calcium gluconate, chloride, hydroxide, calcium lactate, calcium acetate, tricalcium phosphate, and calcium gluconate. So this is a chart which tells us about the bioavailability. So calcium carbonate, it requires acidic stomach conditions before the absorption. So normally the calcium carbonate is taken. Of course, the calcium citrate also has 21% of bioavailability, but not dependent upon the stomach acidity. And so forth, we can give tricalcium, phosphate, lactate, acetate, chloride, and so on. But calcium carbonate and citrate, they are on priority. In calcium carbonate, they don't go for renal stone, so it prevents the renal stone. In calcium citrate, renal stones are not there, and it's safe. The calcium carbonate is safe in patients who have the renal stones. Next, please. So what are the sources in our diet? Milk. Calcium, 1 cup, it contains 300 milligram. Yogurt, 1 cup, it contains 300 milligram. Orange juice fortified, it contains 260, 1 cup. Cottage cheese, 1 cup, it's like 138 milligram. Broccoli, 1 cup, it is 90 milligram. So supplements, I have told you, the calcium citrate and the calcium carbonate. But if you are taking acid blocking medications, calcium citrate should be recommended. No more than 500 milligrams per day calcium should be taken if you are taking the food sources. Now coming up to the vitamin D. So there are 3 forms of vitamin D as we are aware of. Argocholecalciferol, vitamin D2, vitamin D3, that is cholecalciferol, and calcitrol, that is the active form. Vitamin D is available in granules, as we know, the soft gels, the liquids, injection, and the strips. In Australasia, the vitamin D is less than 30 nanograms per ml, and optimum dose required is 60 to 80 nanograms per ml. Vitamin D, the daily dosage is 1,000 to 2,000 international units, but in Australasia, we requires more, that is 10,000 to 20,000 international units. The loading and the correctional dosage, that is 60,000 international units per week, should be given up to 12 weeks. And then per month, 60,000 international units should be given as a loading and a correctional doses in cases of osteomalacia. Next, please. Now, vitamin D, if it is below than 5 nanograms per ml, then loading or correctional dose of 3 lakhs to 6 lakhs international units, deep intramuscular injection should be given, as we are aware of it. Next. What is the goal? Vitamin D, 7 to 800 international units per day should be given. And in a diet, fatty fish, as ma'am has told, the fortified foods, all that, along with the proteins, that should be given. And natural source, that is the sunlight, of course. Early morning sunlight is the best. That should be given because of the exposure to the UV rays. The late hours sunlight is not recommended. This is the flow chart that shows the elemental calcium and the vitamin D that should be given in different stages in infants, what should be given in children, in adults, and in postmenopausal after the 70 years. So calcium is like 1200, 1000 to 1200, and then the vitamin D from 400 to 800. Thank you so much.
Thank you very much, Dr. Arti. That was an important talk with numbers for the calcium and vitamin D. Having heard about nutritional supplementation, we'll move on to Dr. Renuka Panchagnula. She'll be talking on calcium and vitamin D pharmacological supplementation and therapy in osteoporosis. She is the director and consultant pathologist at Chandra Diagnostic Laboratory. She is specifically an immunopathologist. It's from Bangalore. And she's also an IOA Osteoporosis Council member. Over to you, Dr. Renuka. Thank you.
Thank you so much, Dr. Srinivas, for that introduction. Dr. Arti has made my session much easier because she has already covered up a few things which I need to mention over here. Calcium and vitamin D, of course, become very important, and osteoporosis is a condition characterized by disruption of bone microarchitecture, causing decreased bone mineral density and increased fragility, as well as increased risk factor, the fracture. We all know calcium is a major building block of bone, and the skeleton houses about 98% of the body's calcium stores. Thus, bone becomes an important both resource as well as reservoir of the calcium, and it maintains the homeostasis. So when you actually do a serum calcium, it may not give a correct impression because of the tight hemostasis. Adequate intake of calcium and vitamin D is essential for maintaining bone health. And the deficiency of calcium, which plays a very important role in the development of osteoporosis. The lifelong lack of calcium plays a role in the development of osteoporosis. This slide is not moving, just a minute. So Dr. Arti has already covered this, but suffices here to say that calcium need of a postmenopausal increases basically because of the estrogens as well as because of the decreased absorption. Calcium absorption goes on decreasing as the person's age increases. It is very high, about up to 45% when a child, whereas it goes on decreasing as the aging occurs. So when it comes to treatment of osteoporosis is recommended for postmenopausal women and in men aged 50 years and older with a low bone mass at the femoral neck, total hip or spine when we do a BMD. So it has been very clearly documented that calcium supplementation has been effective for preventing osteoporosis fractures in postmenopausal women. Now the concern is there are many formulations of calcium which are available, and this has already again been covered by Dr. Arti, that calcium, it is available as calcium carbonate, which has about 40% of elemental calcium. Tricalcium phosphate has 38% calcium. Calcium citrate has 21%. Calcium gluconate has 9% of elemental calcium, and lactate has 13%. If you look over here, calcium carbonate is the cheapest and therefore often a first good choice because it has a high amount of elemental calcium. So what is important is to look at the elemental calcium. Now there are a lot of calcium formulations which are available in the market as well as for anybody to take on supplements. So what is it that decides which supplement to choose? It is basically we have to look at what is the amount of the elemental calcium which is present. So if you are taking 1,250 grams of calcium carbonate, you will be actually giving 500 grams of elemental calcium because we have said it is 40%. Then comes the tolerability. Some supplements, they do not usually cause, but there are times when some of the calcium tablets may cause some side effects such as gas, constipation, bloating. Particularly calcium carbonate has been reported quite frequently to cause constipation. At that time, just try different type of supplement and brands. Other aspect is, of course, the quality and cost, the bioavailability of the product that we are using, purity, potency, which depends a lot to a large extent on manufacturers, though it is monitored by the pharmacopoeia. But we have to ensure that the dissolution of the tablet, how it is available, is important. It suits to the individual which is being used. The supplemental forms could either be tablets, capsules, chewables, liquids, powders. So what suits are each individual is what is best recommended for them. It is best absorbed when taken in small doses at meal times, usually 500 milligram or less. You should not go beyond that, because then increasing the calcium does not really cause increased absorption. And calcium, so it has to be taken with meal. Only calcium citrate is one drug which can take either with or without meal, even in a fasting state, and recommended particularly for people with IBD or any other absorption disorders. You also have to bear in mind what are the drug interactions with calcium. Calcium supplements are known to decrease level of few drugs such as digoxin. It also causes decreased absorption of fluoroquinolones, levothyroxine, antibiotics of the tetracycline family, and phenytoin sodium. So this is the impact that calcium can have, and this is why they should not be taken together along with these drugs. In addition, there could be drugs which cause interference in the calcium absorption and excretion, like thiazides. They can cause both hypercalcemia and hypercalciuria. Aluminium and magnesium antacids increase urinary calcium. Mineral oils and stimulants like laxatives decrease dietary calcium. And very commonly, when you're treating osteoporosis, you would have recommended bisphosphonate therapy also in addition. But it should be remembered, bisphosphonate should be taken on an empty stomach with fasting about 30 to 60 minutes after having taken the drug. And the problem with if it is taken, calcium is taken along with it. If you are given citrate, it can bind to calcium. Hence, it should be avoided when you're taking treatment with this calcium. The other topic which we had to discuss, very commonly calcium is given along with vitamin D. And the vitamin D, the major function of vitamin D is the regulation of the intestinal calcium absorption and stimulation of the bone resorption, leading to the maintenance of the serum calcium concentration. The calcium is usually, the vitamin D is most commonly taken from by the exposure of the sun is the thing. And you have various forms of calcium where it is basically converted to vitamin D3, then it passes through the circulation, which is called as the cholecalciferol, goes to the liver where it is hydroxylated to form 25-hydroxycholecalciferol, and then into the renal tissue it forms 125-hydroxycholecalciferol. So as I said, there are mainly in the human body, we have two forms, which is the vitamin D2, which is the ergocalciferol, and vitamin D. When it comes to the supplements, Dr. Arti has already covered up that, it is basically the sun, basically best is to do exercise and the sun exposure, as well as milk products and animal products. The dairy products, the medical vegetarian diets usually give us ergocalciferol, which is the vitamin D2, whereas the animal products give us the vitamin D3. Most of the time in adults, what is actually the recommended dosages around the daily requirement is about 600, and which increases beyond 70 years to 800 IU per ml. When you talk of supplements of vitamin D, they are basically, it's well proven that they reduce risk factor and risk of fall in osteoporosis patient, also help in the muscle mass and strength. And vitamin D is, as I've already mentioned, present in two forms, that is vitamin D2 and vitamin D3. Most of the formulations contain vitamin D3, and and there are only about a few which are available, which is there in vitamin D2. When it comes to vitamin D3, again, there are different types. One is the cholecalciferol, which is the inactive form. Then you have the active form, that is which is 25-hydroxycholecalciferol, that is alpha-calcidol, and 125-cholecalciferol, which is the calcitrol. So these are the various forms. And if you look in the market, this is the one which is study which has shown in Indian market. There are so many forms of vitamin D which are available. Some of them are individually available or also along with the calcium or other minerals and vitamins which are available. Coming to here, calcitrol, if you look at calcitrol, it has a rapid onset of action because it is 125-hydroxycholecalciferol with a very short half-life of about 6 hours. It can cause high incidence of hypercalcemia and requires regular serum calcium monitoring. If you have done a vitamin D evaluation before you start the therapy, then you should do an evaluation after about 8 weeks. Then majority of the calcitrol preparations are combined with zinc or zinc sulfate. It is very useful. As I said, since it is 125-hydroxycholecalciferol, it can be used in renal patients also. And whereas other, it is difficult use and it does not build up stores but it is an expensive preparation. The other one is the alpha calcidol, which is 25-hydroxycholecalciferol. That is a rapid onset of action, but with a half-life of 2 to 3 weeks. Does not require a hepatic, because it's already been 25 does not need to go. It can be used in patients with liver disorders. And preparations also contain calcium. Many of these have in combination with calcium. Cholecalciferol is the inactive form, so it is a slow drug, usually available as a single constituent, but a half-life of about 12 to 30 days and preferred form for prophylaxis rather than for osteoporosis. Alpha-calcitriol, calcitriol are commonly available as tablets and capsules, which varying in dosages from 10 IU per ml to about 10,000 of vitamin D, which can be given on oral. But most commonly, when a patient is on having osteoporosis, we recommend sachets of cholecalciferol containing granules of vitamin D, amount of 60,000 IU per, which can be then given for weekly for about 8 or 12 weeks, followed by a monthly maintenance therapy for over a year. Vitamin D, there are hardly 2 or 3 formulations which are available. One is of ergocalciferol, which are available in 20 IU and 100 IU per ml. So when it comes to dosage, basically the dosage rests to a large extent on individual needs, blood levels, exposure to the sun. And National Osteoporosis Foundation recommends an intake of about 800 to 1000 IU of vitamin D3 per day for all adults over the age of 50. Higher doses may sometimes be required if the patient has very severe osteoporosis and up to 2000 IU per ml. The target says 50 nanomole, but there are few recommendations which say that the target of vitamin D up to 30 nanomole is also adequate. Suffice it to say here that adequate intake of calcium and vitamin D play a crucial role in the prevention of management of osteoporosis. The recommended supplement of calcium vitamin is 1200 to 800, which includes both the dietary as well as the supplementation by medications or pharmacotherapy. And it should be supplementation should be along with a balanced diet with lifestyle modifications, exercise, which forms the cornerstone of pharmacotherapy. Regular monitoring is required because sometimes there could be excess of calcium or vitamin D, which can cause hypervitaminosis, or also called as hypercalcemia and hypercalciuria, which can cause problem. Individuals should be told to take only the recommended dosages in small dosages and recommended. And individualized therapy are essential for optimizing the bone health and reducing the risk of fracture. Thank you.
Thank you very much, Dr. Renuka, for explaining to us the different types of calcium and vitamin D. The important message is pharmacological supplementation may be needed in postmenopausal women.
Exactly.
Our next speaker is Dr. Aradhana Rathod. She'll be talking on strategies for prevention of osteoporosis in postmenopausal women. She is an assistant professor in Department of Orthopaedics at Bangalore Medical College and Research Institute in Bangalore. Dr. Aradhana, please.
Sir, is my slide visible?
Yes.
Yes. Thank you so much, sir, for the opportunity. My talk is on strategies in prevention of postmenopausal osteoporosis. Most of it is covered by the previous speakers. So from orthopedic point of view, what exactly we are supposed to tell a patient who comes to us just prior to menopause is what I am focusing on. So if we see the calcium metabolism or homeostasis, the last which I have marked shows that estrogen is necessary for mobilization of calcium into the bone. So when there is menopause, the estrogen level reduces. So the portion of the work which is done by estrogen is not done now. So what we are supposed to do when estrogen level is going down in women. So we have to depend on other factors which can increase the mobilization into the bone. Let us see. Osteoporosis is definitely a preventable condition in most of the people. So as Suma ma'am told, the importance of peak bone mass. That is, we have to start the building of healthy bones while in young, that is teenage and preteens. If our peak bone mass is very good, then we can maximum ways we can prevent osteoporosis in postmenopausal women. So how do we do that? Mainly by taking very good diet and having a very good lifestyle. If we see the picture, most of them are non-modifiable factors like hereditary, gender, and hormones. But some are modifiable like mechanical forces, which includes exercise and nutrition. There are some risk factors. What are they? Let us see. So even in risk factors, there are non-modifiable and modifiable as well. So if we can focus on modifiable risk factors, we can definitely reduce the osteoporosis in postmenopausal women, like having a very good calcium intake during premenopausal time, including postmenopausal as well, to maintain the bone mass. And thinking of, some patients do come to us with chronic steroid use for simple pain in the knee. So explaining them that steroid is not going to help them until and unless it's an inflammatory cause. So minimize the use of steroid use for unnecessary condition. Or another important thing which we can tell from orthopedic point of view is reduce the ethanol use and tobacco use. So if we see, osteoporosis is labeled as a silent killer because until unless fracture occurs, they do not come to an orthopedician, and when they come to us, already osteoporosis is set in. So what we can do, this is for a common person who can access this website, that is Bone Health and Osteoporosis Foundation, where a lot of information is being given regarding the osteoporosis prevention and other things. Now let us see what can we do to prevent osteoporosis in postmenopausal women. Let us take each one individually. So take calcium and vitamin D supplements as recommended, which are already being covered by Arti ma'am and Renuka ma'am. So how much calcium has to be taken in a teenage, how much has to be taken by men, women, has to be kept in mind and taken accordingly, including vitamin D dosage. So maintain the vitamin D levels beyond 30 nanograms and focus on the patients, especially the rickets or having patients with vitamin D deficiency and renal insufficiency. These patients do need supplemental vitamin D. So consider giving supplementation for these kind of patients. So calcium supplement, is it really necessary in premenopausal? Food is best source of calcium in all age group, but definitely when absorption rates are very less, then we can consider giving calcium supplements in those conditions. So this is already been discussed by the previous speakers. I will not go into detail. Having a balanced, rich calcium and vitamin D diet is very, very necessary. This cannot be replaced by any pill or any tablet. Weight-bearing activities or strengthening activity is very important since childhood. BHOF strongly recommends physical activity in all ages. It is either premenopausal, including postmenopausal, in fracture prevention and overall fitness. It starts from the childhood and adolescent itself. Weight-bearing exercise, how does it help? So weight-bearing, especially small impact exercises, these exercises, the osteoblast, and once the osteoblast is stimulated, it causes bone formation and hence helps in prevention of osteoporosis. So consistent weight-bearing and high impact activities are very, very important in acquisition of optimal peak bone mass, which in turn can prevent osteoporosis in postmenopausal. If a woman is already reaching menopause, still she can consider weight-bearing exercises. If not hiking and jogging, at least consider walking and dancing, these kind of activities which are very, very necessary. Other important exercises are weight training, resistive exercises, yoga, pilates, etc. These are very, very important in prevention of osteoporosis because any small amount of triggering factor to the periosteum, which is muscle attachment to the bone, can stimulate osteoblast, and hence it causes increase in bone formation. Lastly, avoid certain things. Smoking cessation is very important because it is negative factor for bone formation. Another important is alcohol intake. Limit to 2 drinks per day for women or 3 drinks per day for men. Reduce, because this alcohol intake reduces the calcium absorption and also causes increase in falls, which are not very good during old age. Excess fiber intake is not very great. Optimum amount of fiber is definitely accepted, but excess fiber, food is being replaced only by fiber, is not very good because it inhibits calcium absorption. Excessive caffeine, sodium and oxalates also has a negative impact on absorption of calcium. So last but not the least, avoid adequate intake of calcium, cessation of tobacco use, reduce alcohol intake, regular weight bearing exercises, muscle strengthening exercises are very, very important in prevention of postmenopausal osteoporosis. Other important things are remediation of the condition associated with falls, such as visual impairment and use of sedating medications, have to be kept in mind while dealing with the patient. Thank you so much.
Thank you, Dr. Aradhana, for such a lovely presentation on the strategies prevention of osteoporosis postmenopausal. Now I invite Dr. Kripa Elizabeth. She's an associate professor in the Department of Endocrinology, CMC Vellore, to talk on bringing it all to the community, miscellaneous strategies, and what to avoid in osteoporosis. Dr. Kripa.
A very good evening to one and all, and to speak on the topic, bringing it to the community, miscellaneous strategies and what to avoid in osteoporosis. It's a rather big topic to pack into 5 minutes, so I just thought about 5 points that I would like to share with you all: educate, enable, eliminate, exercises, and ensure. And I've put first point as educate that we did on 1,500 women. We found that the prevalence of osteoporosis is as high as 40. However, despite these staggering facts, when we actually talk to postmenopausal women, poor awareness of this condition, and what was even more shocking is that even many of optimal knowledge. So when we talk about bringing it to the community, I think it's important that we educate our postmenopausal women, and not only them, also the primary care physicians as to when to screen, whom to screen, how to screen, and how to treat. Make is enable. Again, we do a lot of DEXA scans at our center, osteoporosis, but when we actually look at figures, we find that the number of DEXA scanners away postmenopausal women at risk in our country, and therefore are there any surrogates. So there is this self-assessment tool in Asians. It is calculated as weight minus study that we undertook in almost 5,000 women, where we found that the prevalence of osteoporosis and this index OSTA at a cutoff of +1 and less had a good diagnosing osteoporosis. So in resource constrained settings, one might make use of these screening tools. And to put it in very simple words, any old woman who appears thin is at high risk of osteoporosis and needs to be. The third point that I would like to make is eliminate, and it is here that we would address risk factor, some modifiable and some not. So if you would look at this list, some things to avoid would be smoking and alcohol consumption, which was mentioned by the previous speaker, glucocorticoids, if not required, to avoid that is poor in calcium, improve physical activity, and so on. We also have example if the patient has unstable joints or peripheral neuropathy or is on drugs such as sedatives and diuretics or has a poor vision. These are all risk factors for falls and should be avoided as far as possible. Some of the fall prevention measures to avoid falls in osteoporosis would be to remove home hazards, make sure the floor is not slippery, light up the living space, use assistive devices like direct eyeglasses, and also do a thorough review of medications. And falls are to be avoided. We've heard a lot about building the peak bone mass, etc. So exercise may not increase BMD in itself, but it might help in maintaining the BMD and slowing down the rate of decline. Ensure that women and also encourage them to do balance and posture training exercise repetitions of 4 to 6 weight bearing exercises at least 2 to 3 days in a week, spinal flexion and exercises that involve high compressive forces. I would say ensure that women are screened in a timely manner for osteoporosis and calcium with adequate vitamin D. Encourage them to exercise, enforce vision and hearing, look into their drugs, make sure that they are compliant to anti-osteoporosis, them to schedule frequent visits to a physician or an endocrinologist. Thank you.
Thank you, Dr. Kripa. It was such a really appreciative talk. Now I invite Dr. Swati. She's an associate professor in the Department of Obstetrics and Gynecology, AIMS, Deoghar, Jharkhand. She's going to talk about mental well-being and its impact on the osteoporosis. Dr. Swati.
Yes, thank you. Good evening to all. Happy Shivratri to all. Are you able to see my screen?
Yes, Dr. Swati.
Yeah. Yeah. So I'll be speaking about mental well-being and its impact on osteoporosis and the various strategies for stress management and emotional health. First of all, we all know that mental well-being encompasses emotional, psychological, and social aspects of life. So prioritizing mental health is very important for all of us, not just for the menopausal women, for all. Mental well-being and bone health, they are interconnected because poor bone health can contribute to mental health issues due to pain, mobility limitations, and decreased quality of life. So coming to menopause, women have a cognitive decline and also osteoporosis. It's all because of estrogen, we all know. So they are now at a risk of cardiovascular disease, Parkinsonism, depression, osteoporosis, hypertension, weight gain, midlife, diabetes, and Alzheimer's and all. So all these are interconnected because estrogen, they affect the mental well-being also. And at the same time, estrogen has got a neuroprotective effect by having a cholinergic deficit in the nerve cells. So this estrogen is going to now regulate metabolism when it's deficient. So the metabolism is definitely being altered. There is also increased cerebral blood flow under the effect of estrogen in female brain or nerves. It has been seen to promote dendritic outgrowth. There is effect on nerve growth factors as well as co-localization of receptors, and neurotransmitter synthesis and turnover is also being controlled by estrogen. So at perimenopause and menopause, when there is a decline, so these women are more prone than men to depression, and also it has been found that right from puberty onwards, women are more prone for depression and other sort of mental disorders. There was a survey which found that almost 50 to 75% of women experience some of these mental well-being issues during menopause. So this is actually in the practical aspect, especially in India, it's an unaddressed issue which leads to unnecessary suffering, and multiple comorbidities are now again going to enhance the unwanted outcomes. So what are the predictive factors for this poor mental well-being, and why we are going to see them? So first of all, we need to know what are the risk factors. If there is a history of previous depressive episodes such as premenstrual syndrome and postpartum depression, or some comorbidity, that is menopausal one only, like hot flushes, nocturnal sweating, insomnia, these all women are more prone to having poor mental well-being. Usually, hormone replacement therapy is being advised, but most of them are not being treated. So again, not treating these menopausal symptoms with hormone replacement therapy, this is also risk factor. Some other stress which is existing, high BMI and low socioeconomic level, and some ethnicity group women. So now coming to not only women, also in men, it has been found that 1 out of 3 and 1 out of 5 men at and beyond 50, they have a poor bone density and quality. So a coordinated care is required between all the interprofessional teams to target the issue at the community level. And we need to treat it because it has got an impact on quality of life. It's associated with depression, and it is accounting for disability adjusted life years, and the whole cost is more than what is associated with the common cancers. So how are we now, what we are going to do? So first we need to know that it has got an increased risk of this severe mental illness has got an increased risk of poor physical health, increased level of cardiovascular disease, and these type of persons are going to go have inequalities in healthcare provision. A study has proved that major depressive disorders, they have been associated with low mineral density, and this was seen by comparing the bone mineral density of those having mental illness and the normal population. In them, it was found that the mineral density was less in spine, femur, and neck of the femur. Almost 50% of adults at around 45 years of age with mental illness, they have osteoporosis and osteopenia. This is 2.5 times higher than what is expected in general population. So we want to know why all this, because of mental well-being and all. Because these persons who are not mentally well, they have physical inactivity, which leads to bone loss and osteoporosis. They have changes in their dietary habits. Again, they are not taking proper diet, leading to deficiency of calcium and vitamin D. Chronic stress leads to some disrupted hormonal levels such as cortisol and adrenaline. So there is imbalance in hormonal level, and it is going to affect bone metabolism. Again, they are going to have sleep disturbance because of the mental illness, and sometimes because of the effect of medicine that they are taking. So this sleep habit is also going to affect osteoporosis. Now coming to side effects of medication, long-term use of selective serotonin reuptake inhibitors, they have an impact on bone density indirectly by giving a high weight gain and sleep disturbances. These persons are also more prone to alcohol and substance abuse, and again, it's going to affect bone metabolism. And finally, the social isolation. This is the thing when their physical activity is decreased and exposure to sunlight, that is vitamin D, is now again going to get affected. So social isolation, this is a very important factor. So we are now going to treat it because it will lead to osteoporosis and hence to an economic burden, which has been estimated to be like $131.5 billion by 2050. So basically, the approach is going to be a multidisciplinary one, including we people from Ops and Gynae, orthopedicians, from psychiatry, counselors, dietitians, and physiotherapists. So I'll be basically talking about lifestyle changes, hormone replacement therapy, antidepressants, and cognitive behavioral therapy, and co-treatment of combining these all measures. In lifestyle changes, as are all the learned speakers have talked about physical activity, that is almost 30 to 60 minutes per day, at least 5 days a week, that we all know. That's going to have a good effect on mental well-being also and physical well-being also. In addition to that, controlled yoga and mindful exercises like meditation. Some people say do it 1 hour, not even 1 hour. If they do for 15 minutes even, it's going to have a good effect on their thought process. So these women are and men are also advised to seek social support and connect with friends and families, and they should be prioritizing their sleep so that they have a consistent sleep schedule and have a relaxing bedtime routine to improve their sleep quality. And calcium and vitamin D all have spoken. So this regular exercise is going to increase endorphins, improve their mood, and hence it is going to supplement bone health. Now, I would like to talk about cognitive behavioral therapy, where it is a type of talking therapy. Counselors are going to talk about stress management, and they are going to identify negative thought patterns, and there will be behavioral activation, and by doing all these things, they can prevent the relapse of this mental illness. So, if things are not handled by lifestyle modification and cognitive behavioral therapy, of course, pharmacotherapy has to be given. So in the form of hormone replacement therapy, that is estrogen and progesterone if needed for those women having uterus. And of course, we have to rule out the contraindications before giving estrogen and progesterone. In addition to that, antidepressants are also given for these women. It's not only that hormone replacement therapy will cure their postmenopausal depression. And best one is combination of both, because some studies have shown that this postmenopausal depression that is very resistant to one therapy. So it's always better to give them a therapy of antidepressant combined with hormone replacement therapy. And of course, they need to be given lifestyle changes and cognitive behavioral therapy in addition to this. So that is all about managing the mental well-being for a good bone health and overall postmenopausal health. So that was all. And my take-home message would be mental well-being plays a crucial role in managing postmenopausal or osteoporosis. Incorporating strategies to promote mental health alongside medical treatment is essential for holistic care. That is what we are going to give to any woman who is going to come after menopause. We have to think about her heart health, about her brain health, about her thought process, bone, and overall physical health. By addressing mental well-being, women with postmenopausal osteoporosis can improve their overall quality of life, and that is our target. So that was all, and thanks to all.
Thank you, Dr. Swati. Now we can take the questions, Dr. Srinivas.
Yes, Dr. Arti. I think there's one question that is already in our chat is on the type of calcium that needs to be taken. A question to Dr. Renuka, Jasar, and Dr. Amarnath on what type of calcium is best, calcium carbonate or calcium citrate, and what are their advantages and disadvantages. Dr. Renuka?
This calcium carbonate has more of elemental calcium. So it has about 40% of calcium. So if you have to take, say, 500 grams of calcium, elemental calcium, you take 1250, you just one tablet is enough. The only problem with calcium carbonate is that it has to be taken with a meal. Whereas when it comes to calcium citrate, it has a good absorption, whether you are taking with food or without food. So that is the advantage of calcium citrate. Because of it, the absorption is better. But the number of tablets that an individual will have to take for the same amount of elemental calcium will be more if you're taking calcium citrate compared to calcium carbonate. That is one aspect. But if the patient is taking antacids or the patient has any inflammatory bowel disease or any of the, they're taking omeprazole or any other antacids, at that time citrate is a better drug to be taken compared to calcium carbonate. The other aspect is calcium carbonate is cheap. So I think this needs to be individualized because how much of calcium is required for a person. And if you're just taking it as a regularly and you want to take it at any time, generally when women want to take, they start taking earlier itself calcium. At that time, maybe a calcium citrate might be a good choice with a provided they can afford. But when you talk of the population at large, and particularly when we talk of Indian population, we want them to take the medication. Probably calcium carbonate would be a better option because it will give more elemental calcium to them, is my opinion. But probably the best would be the orthopedicians who prescribe them on the regularly, Dr. Jha sir and Dr. Amarnath, probably they'll.
Right. So the talks have focused principally the two talks on calcium and vitamin D. When we talk about calcium, we forget also about some other related products like zinc, boron, magnesium, even vitamin K2. And talking of calcium, now, if you want to add boron, there is another calcium, calcium aspartate, which also gets easily absorbed. And because it is conjugated with boron, this could be preferred. So we cannot have a static rule that always calcium carbonate is the only one. Calcium citrate malate is another one which almost has a parallel elemental calcium. And rightly, Dr. Renuka has said that it is not the amount written on the tablet or the capsule that the patient is getting. It has a basic inbuilt elemental calcium that you have to be aware of. And next, what is important, when a patient is prescribed a calcium preparation, you have also to see how much of dietary intake she is getting. What is the kind of absorption because of the comorbid conditions that the patient may be having. So there are many issues, but it is very important that it is the inadequate calcium supplementation which primarily is responsible for development of osteoporosis. Naturally, calcium goes hand in hand with vitamin D.
Amarnath, sir.
I agree with, yeah, thank you, Srinivas. I think I agree with what Dr. Renuka and Professor Jha mentioned about the calcium and vitamin D. Now, one word, one comment on the diet, obviously, and the dosage of calcium. It is better divided than one tablet. If somebody, most of us in India, from north to south, all of us have the phytate diet. Calcium carbonate or even citrate has a little issue with the citrate, with the phytates in our diet, which causes some amount of challenges. Dr. Jha mentioned about, and even Renuka mentioned about the IBD, with this irritable bowel syndrome and the fatty habits of our food selection and the comorbid prevents us from having the proper nutrition. Hence, supplementation is a stay. It has to be considered. And I have been recommending and I've been taking myself for a long time now calcium. I've seen the benefits and I've seen the effects of the patients as well. It is not just talking about the bone, even the joint pains get better because in menopausal women, what is happening is bone is getting softer. With calcium and vitamin D, the bone gets stronger. The pain in the joints are much, much well tolerated because the musculoskeletal activity also contributes to the better circulation and healing power in and around the joint. So it is not just only to highlight one or two points, but I just covered a few points to add on what Dr. Jha and Dr. Renuka said. Hope it makes sense. Thank you, Srinivas.
Thank you, sir. One question to Dr. Suma. This is regarding, is there a role for supplementation in children, and what advice would you give to schools, colleges, and parents to increase the bone mass in children?
So I think that's really important. So nutrition is a very important part, of which, one of the best combination of protein and calcium is dairy products in children. And of late, there's been a lot of bad press against dairy products, which I think is very ill-advised. We ought to encourage, good dairy intake in children, because that is one of the best ways to get it in. And plus all the other foods that Renuka was talking about regarding nutrition. The other extremely important thing really is physical activity. Something that our children are really, really, really not doing enough of nowadays. And we really need to get children outdoors doing physical activity. I'm really worried that we are growing up a generation of children who are going to have very poor bone health.
Yeah, thank you. Yes, sir, please.
Amarnath, you wanted to say something? Right.
Yeah. So, sorry, I couldn't hear. There was a lot of noise in between. Sorry. So thank you, sir. Now, I agree with what Dr. Suma said, because that is the most essential. Today, what is happening is I typically show in my slides, we have malnutrition. We learnt about it, but we see about it. But today, what's happening with children is malnutrition. M-A-L-L, mall. When they go to public, all the big malls are coming in, and we end up having the malnutrition, which is literally the fast food, which has absolutely no bearing. And then she talked about caffeine drinks, and it's been loaded with caffeine drinks. And children just love that. So the malnutrition to malnutrition, it's a very, very difficult thing. And then obesity, in childhood obesity, and all that going on and on. I think I agree with Suma, physical activity. And many of the schools in the cities, because of lack of space, they don't have the playground. And the only thing they play around with their fingers is their tabs, mobile phones, and that's it. And it's crazy. I think we need to change it. We need to address this in a big way. Food fortification, not only for geriatrics, but even for pediatrics, is extremely important. And as we were in our postgraduate and even in our, housemanship, we used to have the local PSM postings when was done. We used to encourage the legumes, the cereals, and then the local food, millet, how they can make it. I think that will be one of the key fact area where we can address it with economically giving it and using the local food, local for local kind of a challenge address in a big way will make a massive difference in our country. And the government is focusing on the nutrition and wellness centers in a very big way. In a few months' time, we're going to have a massive change happening in that front. I'm really happy about that. Thank you. Thank you.
Thank you, Dr. Amarnath.
Yes.
Yes, sir.
Right. Dr. Amarnath talked about obesity, and especially he talked about obesity in children because that was the relevant part. But obesity has no boundaries. Like osteoporosis, it travels from pediatric age to geriatric age. And I only wish to highlight one thing, that it is aging which brings about inflammation, and it is the fat located in the whole body, either the visceral fat or superficial fat or even fat in the bone marrow, that they have adipocytes, and these adipocytes, they hypertrophy, and finally they are responsible for production of osteoporosis. So it's a very wide spectrum subject in which we know that obesity can lead to other metabolic syndromes which can give you systemic diseases, but also osteoporosis and osteoarthritis.
Thank you, sir. It is unfortunate that board marks are being given priority over bone mass, as Dr. Suma had mentioned. Sir, Amarnath, sir, you have something to say?
Yeah. One, in fact, Dr. Kripa was mentioning about osteo. One point I think I would like to add on to what all the speakers have said is the frac scoring. In our country, we do not have access for
Yes.
the DEXA in a big way. So fracs would be one of the biggest pointers. Today, each and every person having a mobile phone, even in the street vendor, can access his or her bone mass by a frac scoring, which is India specific. So I just wanted to add on to that. Thank you.
Yes,
You want to say
sure.
something on that, Doctor?
Yeah, we've done studies
Yes, Dr. Kripa, please.
on fracks as well, and we've actually shown the fracks actually performs well in predicting prevalent fractures. However, it does not incorporate all the risk factors like history of falls, etc. So this last May 2023, Professor Eugene McCloskey has brought out the Fracks Plus, which allows for such modifications, such as how recent the fall was, the site of fracture, this fracture risk, Fracks and Fracks Plus are tools that can be used. I agree with you, sir. I didn't put it in for want of time.
Sir,
Thank you.
Is there a merit in training the population how to calculate their own fracks? How valid, how useful would that be?
Yes, they just need to have they can do it online. Yes.
Okay. Has there been any study
without the BMD? We have studies from our own center, sir, fracks with BMD and without BMD, and we have study from our own center. Yes.
Thank you.
So this is basically a Singapore study, and we are aware that Vellore has done your own studies, and you have presented them also. Dr. Srinivas.
Yes, and actually you mentioned Singapore. So the database of Indian BMD used in the Fracks India is from the Singapore Indians.
One thing, Dr. Srinivas.
Yes, sir.
All right. Salt, sugar, and caffeine. Three things. Caffeine has been talked in, I think, the pediatric case also, and elderly ones or adult ones also. So there is a definite impression that caffeine will cause osteoporosis, so caffeine should not be taken. But I think this cannot be formulated in a straight sentence. If we take 100 milligram of caffeine daily, this will eliminate 6 milligram of calcium from the body. But it is observed that if you consume up to 400 milligram, it is not going to affect the bone, what you can say is affect and produce osteoporosis. So the threshold is at about 800 milligram per day. So up to 400 milligram you can consume, and hence up to 6 cups of coffee can be taken. Now, the last paper was talking about mental problems, and coffee could be one. If coffee consumption is giving you less sleep or you have a racing mind, then in that event, coffee should be stopped. Now, I talked about, yes, any comments in between? Oh,
After you finish.
all right. And I was talking about salt. Salt also can deplete calcium, but then what happens if salt depletes calcium, additional calcium if we take is compensated. So a optimum high salt intake may not affect if the calcium supplementation is good. But the same is not true for sugar. Even if you are not a diabetic and you are taking a lot of sweets, that may unbalance the calcium. Hyperinsulinemia might take place, inflammation might take place, and so sugars have to be taken with a word of caution. But at the same time, it is also said, do not restrict your brain. If you are too tempted to take a sweet, do take it, but with little protein, definitely. Anybody else?
I just wanted to say,
Right.
I mean, Sir's point on caffeine is extremely important because especially in adults, there is actually increasing evidence that black coffee is really good for your liver health. So, fatty liver being a big problem these days, one of the ways to reverse fatty liver in the earlier stages, actually they recommend good intake of black coffee. So balancing what may not be good for one organ may be actually good for another one. So we have to balance things when we take. Similarly, there was a thing about red wine in moderation being good for cardiac health, but at the same time, any form of alcohol is bad for the liver. So everything comes in checks and balances. For children, however, caffeinated beverages are not recommended. They are really found to be deterrents of peak bone mass and bone modeling. So they're not recommended. In adolescent age group, they say you can have a very small limited intake, but prior to that, they're not at all recommended. Thank you, sir.
Maybe last question, anybody?
So what about collagen along with calcium, vitamin D? Dr. Jha, Dr. Amarnath?
No, you want to talk about collagen for osteoporosis or?
Osteoporosis regarding collagen in relation to osteoporosis. Is there any contribution of collagen?
I am not very much aware of when we are talking in terms of osteoporosis and collagen. If you have any information, you can add on, but they definitely become important when we are talking about osteoarthritis or joint degeneration.
Yes, sir, because in bone health, what I mean to say that in bone health, is there any significance of collagen? Because we have been studying only in that osteoarthritis and degenerative. So it's just like it's a multi-dimensional osteoporosis, just like weightlifting, strength training, to eat vegetables, consume calcium, proteins, vitamin D, K, as you have talked about boron, so low calorie diet. So yeah, collagen in one study I have heard that it do contributes to the bone health, but I'm not sure. That's why I was asking that. Is there any role of collagen in bone health?
So,
Yes, anybody?
yeah, I'd just like to answer that question. There is a company who is marketing collagen products and talking to us about its use in osteoporosis. but there have only been few short follow-up that has shown some minimal improvement in the bone mineral density and the bone turnover markers. But in terms of therapeutics, I think it is too premature to recommend collagen products for treatment per a nutritional supplement. For example, when patients are given denosumab, they are dosed them something, that sort of thing. I don't think it can be recommended for treatment alone.
Thank you, ma'am. Thank you, sir.
If I'm reminded of visits to USA stores, and when you go to their stores, there are very many supplements available in large packets, and people keep on buying them. They don't have evidence for their use, and I think these are one of such products. Another point, with permission of Dr. Srinivas, I wanted to highlight that microbiome, they have become very important these days, not only for rheumatic diseases, but also for osteoporosis. So you have to have nutrients to the kind that microbiomes, friendly microbiomes, they get the nutritional value. Like what we should take? Curd, fermented vegetables. So they many a times help the microbiomes, and they may finally help preventing osteoporosis. So that way that becomes very important. Yes, Dr. Amarnath.
Some talk about plant protein being better for the microbiome than the non-vegetarian protein.
Right, you are. Yes, Amarnath wanted to say something.
Yeah, I think adding on to what you said, prebiotics and probiotics are already available, and those are the ones which definitely I think recommended even in arthritis, be it rheumatoid or ankylosing or even IBD, and osteoporosis. Obviously, when once the microbiomes are gut is well regulated, the absorption gets better. Naturally, the nutrient which is supposed to be added on the diet, supplemented, digested, assimilated, will reach the spot of the bone on all over the body. So definitely, I think I agree with you, Dr. Chav. We need to have one, the natural way of taking through the diet, and other one is supplementation, either pre or probiotics. And I have definitely seen the benefits in patients, and I would definitely recommend that. But collagen, as Dr. Elizabeth was saying, and what you said, I think I 100% agree with you. It is just one of those marketing at this juncture, as we do not have much of evidence. They're trying to push the product to another indicative kind of a health supplement. That's about it.
One last point that I would like to highlight in reference to the last presentation on mental issues. If there is ill nutrition brain, there could be some loss of neuroplasticity, which normally should be there. So proper nutrients for maintaining neuroplasticity of the brain, which again includes all those substances that we have talked about, are important. Their protein also becomes important. Their fibers also become important. So this thing also has to be taken care of. And lastly, I would like to say that certain switches in the brain, genetic switches in the brain, have been discovered which maintain mental tranquility. If these switches have been taken off, it has been found that the patient might become depressed, or there may be some psychological illness. So a lot of work is to be done on them, but they have been worked out both in human and experimental animals.
Dr. Aradhana, you have something to say?
Yes.
Yes, sir. Sir, I have seen many orthopedicians using anabolic steroids, especially in osteoporotic individuals. What is it recommended, not recommended, or we have to what are the, yes, sir.
Very good question you have raised. We
Yes,
have
sir.
faced this question multiple times.
Yeah.
In fact, anabolic steroids are one which has a questionable value as far as osteoporosis is concerned. Sometimes it could be used in adolescents in conditions like maybe osteogenesis imperfecta, but not exactly it should be highlighted as a method of treatment of osteoporosis. And
Yes.
talking about management of osteoporosis, we have to be very conscious that it is to prevent the fragility fractures in the vertebral column. So VCF, vertebral compression fractures, do not take place. Number two, the hip fractures and other fractures. The fractures around three places become so very important. And they were not the subjects to be discussed today, that how do we find them out. Dr. Renuka had her research paper on how to evaluate pathologically even before treatment and after treatment, and what exactly are the drugs that are to be preferred. Maybe we discuss them in some next webinar. But I must say, Dr. Srinivas and Dr. Arti, you have framed a very well-knit basic course on this osteoporosis. And on this International Day, I feel so very happy to be with you all. Thank you very much from my side. Dr. Srinivas.
It was an excellent course. We thank all the speakers for the great talks they have delivered, and it was a great discussion. Very important points discussed. I would like to thank everybody for the inputs. Dr. Arti, please.
Thank you so much, Dr. Srinivas. And I thank all the speakers, Dr. Jha, Dr. Amarnath, and Dr. Ram Chaddha, IOA, WOICE, and Geriatric Orthopedics. And on this International Women's Day, it was such an informative talk. And I think so it will be live on the YouTube. I think so, Dr. Srinivas. So it's an educational also thing, because I was also not aware of few things. And I also become, aware of these are very small things, but when it comes to bone health, it's very important. And thank you so much once again. Good night to everybody.
Right. And
Thank
before we
you so
really
much.
leave,
Wish
I
you all.
once again must compliment Dr. Arati. In our conversation, very many times, I have found that she has a great appreciation for nutrition in orthopedics, especially for osteoporosis, and she also talks about it in rheumatology. And today I could sense that all these talks are hovering around nutrition. So thank you very much for taking your very favorite topic. Yes, Madam Renuka, you were saying something.
No, sir. Thank you so much. Thank you for the opportunity. Thank you for the Indian Orthopaedic Association, WOICE, and Dr. Srinivas, Dr. Arti, and you, and all of you for giving us this opportunity and to come together. Wish all the women over here a very happy Women's Day.
Really.
International Women's Day. And
Yes.
good night. Thank you.
Right. So it's time to
Say goodbye, sir.
All right.
Goodbye.
Bye. Bye.
Good
Thank
night.
you. We can have it again. Right.